If you're a nephrology resident on a busy service, you know you need a rock-solid framework for electrolyte emergencies. So today, we are going to break down hypernatremia, pulling from the Manual of Nephrology to give you a really clear, high-yield clinical approach that you can literally use on your next call. Okay, let's just jump right in. The lab alert pops up on your screen, and there it is, a high plasma sodium. That is your signal. Anything over 145 milliequivalents per liter, and you are officially in the hypernatremia zone. Now, before we get lost in the weeds, let's get one fundamental concept locked down. You know how hyponatremia can be all over the place? Hypotonic, isotonic, hypertonic? Well, forget all that. Hypernatremia is beautifully simple in this one way. It is always a state of hypertonic. Always. Remembering that single fact is going to simplify your entire workup. All right, here's our game plan. We'll start by reframing the problem as an issue of water. Then we'll nail down the single most important first test. We'll walk through the algorithm, figure out what to do with a polyuric patient, and finally, we'll talk about how to fix this safely. Let's do it. First things first, we have to completely reframe how we think about this. Hypernatremia. You know, it's not really about having too much salt. At its core, it is always about not having enough water. So if you're going to remember one thing about the pathophysiology, let it be this. Every single case of hypernatremia boils down to an electrolyte-free water deficit. That's it. Your total body water is just too low for the amount of salt you have on board. Full stop. So how do we get there? Well, it really comes down to two main pathways. Either you're losing water-rich, salt-poor fluids, or you're gaining a ton of salt. But honestly, the third point here is the real linchpin. No matter what's causing it, hypernatremia can only happen if the patient can't drink water. That's the universal requirement. And this right here, this is where your clinical detective work really begins. A healthy thirst mechanism is an incredibly powerful defense. Hypernatremia only ever happens when that defense fails. So you have to be asking yourself, why didn't my patient just drink some water? Are they stuck in bed? Are they intubated and sedated? Or maybe have they lost that sense of thirst, which we see all the time in our elderly patients? Finding that answer is your first job. Okay, section 2. We've got the why down. Now let's talk about what's next. To really start building our differential, we've got to look to the kidney and ask it what's going on. So, picture this. You're looking at that sodium of 158. It's staring you in the face. Besides just rechecking the labs, what is the one test you're going to order that will crack this case wide open and point you in the right direction? It's the urine osmolality. That's it. This one value is your master key. It tells you everything you need to know about how the kidney is responding to this hypertonic state. Is it doing its job and trying to save water? Or is it actually the source of the problem, just letting water pour out? And just like that, with that single number, you're at a critical fork in the road. That U-Osmo is going to put you on one of two totally different diagnostic paths. So we get it, right? A high urine osmolality means the antidiuretic hormone system is doing its job. A low one means it's failed. But what's the number? In the real world, what is the clinical cutoff? How concentrated does the urine have to be for us to say, okay, the kidney is responding appropriately? This flowchart is basically your playbook, and the magic number to burn into your brain is 800. If that urine osmolality is greater than 800, the urine is maximally concentrated. That tells you the AVP system is intact, the kidney is getting the signal and responding correctly. So the kidney is not the problem. You need to start hunting for extrarenal water losses, think GI tract or skin, or a big sodium gain. Now, on the flip side, if your U-osm comes back less than 800, well, that urine is inappropriately dilute for someone who is hypernatremic. And that points the finger directly at the kidney. The kidney itself is the culprit. It's where the water is being lost. And your entire workup now shifts to figuring out why your patient is polyuric. All right, section 4. So we've identified the kidney as the problem. Now our job is to play detective and figure out why it's dumping all this water. What is driving this massive diuresis? And your next question really boils down to this. Is the kidney losing all of this water because it's being forced to get rid of a bunch of solutes, an osmotic diuresis? Or is there a fundamental problem with water handling itself, a pure water diuresis? This algorithm shows you exactly how to figure that out. You're going to start by calculating the 24-hour osmolar excretion rate. If that number is high, we're talking over 1,000, then you've got yourself an osmotic diuresis. Think glucose, think urea. But if that rate is low, It's a water diuresis, and that sends you straight down the rabbit hole of AVP deficiency or resistance, what we all know is the workup for central or nephrogenic diabetes insipidus. Okay, we've worked through the whole diagnostic puzzle. Now for the final and maybe most important part, let's build a safe and effective treatment plan. Now this is a massive clinical pearl, so listen up. With hyponatremia, we are all terrified, and rightly so, of correcting too fast and causing osmotic demyelination. But here's the thing, this is not hyponatremia. With hypernatremia, the risk profile is completely different. Rapid correction has not been shown to cause bad neurologic outcomes. That's a huge shift in how we approach management. So, what's our target? The goal you should be aiming for is a drop in the plasma sodium of about 10 to 15 milliequivalents per liter over any 24-hour period. That is a safe, effective, and totally reasonable target for your therapy. Your management plan is always going to have these 3 core parts. Number 1, and this is the most important, treat the underlying cause. Stop the losses or the gain. Number 2, you got to calculate the free water deficit so you know the scale of the problem. And number 3, give that water back, either with oral water if they can drink, or with hypotonic IV fluids like D5W if they can't. And this brings us to our final and honestly our most important takeaway. Fixing the number, that's only half the job. You have to remember what we said at the beginning. Hypernatremia is a disease of a failed defense system. So your real goal isn't just to make the lab value look pretty. It's to restore your patient's ability to sense thirst and to get to water. You have to fix the thirst deficit, because that is the only way you truly solve the problem and make sure it never happens again.